Good afternoon, everyone. I'm John from HTN, and welcome to this webinar today, and thank you for joining us. For this session, we will discuss transformation and the journey to digitisation of health and care, and we will hear from our panellists in terms of their projects and programmes. We'll discuss what to consider for successful transformation, what's working well, and why it's working well. And we'll also ask what's key to achieving the future NHS transformation aspirations. So we have some interesting questions to cover. So I'd like to welcome our panel joining us today. So I'm pleased to welcome Dr. Tamara Everington, the Chief Clinical Information Officer and Haematology Consultant from Hampshire Hospitals NHS, Emily Lucas, the Innovation Facilitator at University Hospitals Coventry and Warwickshire, Dr. Julia Dawson, Innovation Lead at University Hospitals Coventry and Warwickshire, and Innovation Manager at West Midlands Health and Wellbeing Innovation Network. Stefan Chetty, Director of Public Services at Restore Records Management, and Matt Sim, Head of IT Design at Restore Digital. So welcome to the panel and thank you for joining us. Just a couple of things before we start, and they are some housekeeping things. This session is being recorded, so you can watch it back at a later date, and the HCN team will be writing up the key themes, so you can read or watch the session back at a later date. If you have any questions during the session, please type them into the Q&A section, and they'll come directly through to us on the panel, and I'll keep an eye on those as we go, and we have some time for a planned Q&A towards the end of the session, so type in any questions there. So I think a good place to start would be in terms of some wider introductions. So Tamara, could I start with you, please? Could you take us through your role and remit in organisation? I'm keen to hear where your organisation is on its digital journey and your journey to be paper light.
Thank you, John. Thanks for the invitation. So I'm a blood doctor who sort of fell into the world of digital when I realised we didn't really have a planned approach for taking our organisation forward. And as a trust, we became part of the GDE, the National GDE programme, and we were fast followers to a neighbouring acute provider in Southampton. And that was really helpful in sort of accelerating our digital journey. And we made a huge amount of progress through COVID. And we are now a largely digital organisation, which has been based on a sort of best of breed and integrate type approach to going forward. But we're currently in the position of trying to procure a shared PAS and EPR with core functions across our acute provider footprint within the integrated care system. So we're sort of progressing two things at the same time at this point in time. And so I guess in some ways, some of the things we're doing are really forward thinking and exciting, like our patient engagement portal is part of the NHS app Wayfinder program. And that's great. That's really cutting edge, informing patients, engaging them digitally with their care. And we've got things like digital prescribing and all of that sorted out, but we're still on our journey to scanning in our documentation, and there are other areas that we need more thought about. So we've got like 95 clinical digital applications. So I'd say mixed is where we are on our journey.
Fantastic. Thank you, Tamara. And Julia, can I come to you next, please, in terms of your role, remit and organisation? Can you take me through some of the UHCW innovation processes and any projects you're working on in relation to digitising the old paper records?
Yeah, hi. So I'm Julia. I'm Innovation Lead at UHCW. We have a number of projects going on at the minute, as always. In the innovation team, we're responsible for both bringing innovations into the trust, but also supporting staff with their own ideas. So they might have a great idea for a new app or surgical tool, and we're the team that will help them make that a reality and maybe even go on to commercialize it. In terms of our digital journey, we've got EPR coming this June. It's not our first EPR. Some of our teams are already digital, but it's the first time that the entire trust will be on the same EPR. So that's had a lot of exciting developments in it. But in terms of our team and the paperless approach we're taking, we're about to start a project on how we can explore what digital consent might look like and how that fits into the wider sort of health inequalities ambitions and perhaps language services. And projects we've had more recently, there's the UHCW Speak Up app, which was a staff idea submitted by our Freedom to Speak Up Guardian, and it's essentially a digital way of reporting any concerns that staff or patients might have anonymously, which previously might have been a piece of paper under a door maybe, and there's now a digital option for that.
Excellent. Thank you for that. Stefan, welcome. Can I come to you next, please, in terms of your role, remit in organisation and working with a number of NHS organisations across the country? What have you seen in terms of those organisations digitising paper records? Where is the NHS, would you say, as a whole, in terms of digitising paper records?
Thanks, John. Hi, everybody. My name is Stefan Chetty. I am Director of Public Sector Services for Restore Records Management. For those of you that don't know Restore, ultimately we're responsible for supporting organisations in all areas of the document lifecycle. For the NHS in particular, that can be the creation of new notes where that still happens in terms of paper, but really it's focusing on the future for the NHS. So the off-site storage, ongoing retrieval of records, the outsourcing and management of some administration functions like clinic prep and loose filing, ultimately then helping those customers to transition to the digital future in a way that's most appropriate for them, which would include the shredding of the original documents if scanned in the right way. Now, on your question around digitising paper is arguably a bit of a trick question, because digital transformation in the experience that I've seen in the NHS doesn't begin and end at scanning paper. There are many more facets to that, and how information is created and used is part of a bigger picture than just the legacy paper. However, something I wanted to talk about today is let's not lose sight of that legacy paper as part of that solution. And what I've seen within the NHS over many years is, whilst there are some trusts that have very successfully gone digitally, there are many trusts that aren't as digitally mature as that, and the variance within that middle bracket are quite large. And whilst paper is often seen as part of the problem, I actually think there's an opportunity to look at that as part of the solution if managed in the right way.
Very interesting. Thanks, Stefan. I'm keen to dig into that a bit. But just to finish off the introductions, Matt, can I come to you next, please, in terms of your role, organisation and experience in this space?
Hi, everyone. Thanks for attending today. So I work within the Restore Group as part of Restore Digital. I've been within the organisation one way or the other for the last 20 years, and over that time we've probably taken on, 2, 3, 4 various sort of NHS driven projects every year over the last 20 years, which means we've had quite a broad range of experience, and that's both sort of first-hand helping trusts digitise their physical records, but also providing solutions and systems. So whether we're providing scanners on site where people want to really get hands-on with documents and scan them yourselves, or we're providing that as a managed service. I think we're sort of quite uniquely positioned where we sort of offer that sort of full service across the board. We work outside of the NHS, of course, but I think what we've been able to do is pull a lot of that experience from all various sectors and start applying that to how we sort of transform digitalised records and really start getting some real value out of them.
Great, fantastic, thank you. Emily, can I come to you next, please? In terms of how does the innovation team work, and how do you go from understanding a challenge or idea to then having a solution? Could you just take me through a bit of like your methodology from that point of a challenge to the solution?
Sure thing. So we have four main work streams that we follow. Ideas development, when it's someone's got an idea for something, and we would do things like brainstorming sessions, prototyping workshops, design thinking exercises, making sure that the right stakeholders are involved, and if it's patient driven, involving patients as well where possible, making sure that all the right people are involved, and feedback so that the right solution is created. We also look at strategic challenges and opportunities where maybe someone doesn't have an idea, but they have a problem that they think, especially with digital, that they think maybe a digital tool may be able to help them. And we, for that, we can either do it internally or work with partners to develop something that can solve these problems and is the right fit for them, whether it's an existing adopting an existing solution or developing something bespoke. We also have innovation adoptions work streams where, similarly to the challenges, we do more service evaluations for existing products to make sure that they're right fit for what a clinician or section needs. And we also focus on building partnerships. So whether we'll partner with either academia or experts to expert organizations to come up with solutions based alongside their resources and expertise. So we're all bringing in what we know and making something that will create an impact. So we usually do these type of things using the methodology of the double diamond approach, which is a discover, define, develop, deliver process, where we'll go through research, finding, doing interviews and focus groups to come up with the right problems. To make sure that we've got the right problem, and then we will go through the discover and deliver phase, where we would start visualizing what this solution would be like and how it would be implemented. So that's our processes.
Fantastic, thank you. Stefan, can I come back to you next? So you've mentioned around organizations that are not digitally mature. What are some of the challenges that you've seen that those organizations have faced? But then what are some of the practical examples that they could take from being digitally not very mature? What would you say there?
Yeah. So I suppose it depends how you look at it. So there's a number of challenges. I think one of the things is less of a kind of tactical, practical thing, more of a perception thing, in that digital transformation in the NHS, it focuses on the outcome of being digital. And I think there are many trusts, like I say, that are so far from that. It's not meant as a criticism. I think actually in health records in particular, those departments have worked with probably not much funding for many years and have evolved over time without the specific focus on the paper. But there are trusts that still heavily reliance on paper, and the outcome of digital is, it's not just about getting the right EPR in place, because many trusts are some way on the journey towards identifying or having selected an EPR. If legacy paper is required as part of that solution, which is still an if, the practicality of getting that into that system probably hasn't been fully considered in many cases because it's not seen as the major outcome. And there are natural challenges that present themselves in a paper solution that probably, like I say, isn't seen as part of the solution, in that there's the obvious space problem. Every hospital I go into, that is the major challenge that they all say, that they need more space, and often those records are stored in prime clinical areas. There's the cost and the productivity factor in terms of potentially bank staff and recruitment of staff to deliver that service on site. The standardisation of processes can be a challenge as well, in terms some of those processes are quite out of date. So the efficiency of how those work can present their own challenges. But like I say, that's just something that's kind of evolved over time. And then in a paper world, what often then happens is that creates challenges for notes availability as well. So again, I'm probably slightly preaching to the converted here, but you'll often get notes that are, if it's in a physical world, essentially retained around the hospital because they were needed for one episode of care, but then the follow-up appointment, then those notes aren't necessarily immediately available. So unless they're returned within an SLA, then the re-retrieval of those notes for a future appointment can be a challenge. We've seen up to 30% of notes that are required for clinic that are actually somewhere around the hospital. So from a practicality point of view, that presents its challenges. And then you've got the situation then with creating temporary notes and where the loose filing goes, because often temporary notes are then created. If the original note can't be found, then you end up with multiple sets of notes for the same patient, which from a governance and from a practicality and cost point of view, again, presents its challenges. You've then also got the challenge of multiple locations and transferring physical notes to multiple locations within a trust, which again, from a transport cost and time point of view, can present its own challenges as well. And kind of my point with that whole thing is that there are some things that are actually quite far from digital transformation that could be done with that digital transformation in mind to make a transfer over time far more practical. There are some steps that could be taken that tackle those very kind of hands-on kind of practical problems that then mean the future digitisation programme is far more cost effective and likely to happen sooner. But if they're detached from a digital solution, then actually the switch over to digital can be more of a challenge. There's more of a big bang, more of a difficult culture change. You've got a legacy paper challenge that has not been kind of transitioned over time, which then makes that, if scanning of notes is going to be part of the strategy for the trust, probably quite a costly exercise.
Interesting points there, Stefan. And Tamara, can I come to you next, please, in terms of some of the challenges you have seen in terms of transformation, and where is your organisation at in terms of the journey to digitalisation, following on from what Stefan has said in terms of actually the short-term requirement to be dual digital paper?
So there's a bit of me that almost hates the word digital, really, because ultimately we're working in the context of the National Health Service, and our object shouldn't be to be more digital. It should be to be providing a better service for patients. And in order to provide a better service for patients, we need to be freeing up time for our staff to do the jobs that they were trained to do. I just want to just dwell a bit on the trained to do bit, because I've just done a paper for our board. I was asked to answer the question, what assurance can you give us that our staff are capable and competent to use the digital systems that we've got in the organisation, particularly focusing on the business critical systems? And you're all smiling, so I'm guessing that you would all realise that actually I could provide no such assurance. In fact, the more we looked, the more we realised that even very senior people in the organisation, and perhaps the most senior people in the organisation, would often get trained on digital systems and then be really frightened to engage or use them because they thought they were going to break them, somehow mess them up, or just look stupid when they're maybe not used to looking stupid on a day-to-day basis. So we're working with people to make systems and processes better. And in that regard, I think Emily made some really important points about we need to understand the problems that we're trying to fix and respond to that in a really positive way, and a structured way, doing the really hard work to plough through all the little questions that come up along the way. As Stefan said, you know, the multiple case notes, or when we're in partnership with Restore at the moment. Thank you very much, Stefan. Great working with you. Those issues that arise. Okay, so you've gone paper free. We're scanning into a document management system. We've gone paper free, but now we're not printing off labels for outpatients. Now that should be okay, but the point of care testing devices need you to scan a barcode to be able to enter the results safely. So if you haven't got those labels, how are you going to do it? So I'd say that's the really hard nitty-gritty work that needs to be done on top of understanding your problems to take forward your digital solution so it actually delivers at the end of the day something that is better for patients and staff.
Great. Thank you, Tamara. Matt, can I come to you next, please? So how about the same question for a more digitally mature organisation? So yeah, Stefan's spoken about those that are less so. Are there any differences for those that are digitally mature? What are some of those challenges that you've seen, and how might they be overcome? Are there any differences there?
I mean, obviously there's some similar issues. I think it comes down to that sort of digital maturity, because it is a journey. You know, we talk around every organisation, public or private, you know, at a different stage in that journey, and everyone presents with slightly different challenges, whether that's people, whether that's some legacy systems. And I think typically when you look at technology, or wherever you are on that journey, you're dealing with both sides. You're dealing with you know, some legacy technology that you need to try and integrate to maximize, because just removing the paper, that's a small step along the way, if you like, to get systems to talk, to actually gain the efficiencies that you want, because that's what we're trying to do here, isn't it? We're trying to provide a platform to provide efficiencies, as you mentioned before, just to free people up to really do the real job. So I guess when we look at a more digitally mature organisation, you know, you still get some of those challenges. I mean, partly it's to do with just the pure pace of evolution of technology, because, you know, you look at organisation that may have a 5-year strategy, and you look how much technology's evolved in the last 5 years, you know, you quickly see that the challenge isn't about, you know, what you're doing, it is how you keep up. And that's one of the biggest problems. I mean, us as an organisation, if you look at what we're doing and what we're favouring and we promote now, so much of that's based on new technology. We're really promoting a lot of cloud-based technologies and improvements that we gain and we provide to our customers from some of the AI extraction and content enrichments of documents. But the problem is, if you don't have a platform that sort of evolves with that, and you can't utilize that new technology, you very quickly end up with a platform that's legacy, you know, before you've ended up, you know, fully deploying your full implementation. So I think, you know, it's a challenge to, you know, have a long-term view of what you want to do, but try and keep up to date with technology as it goes, so you are maximizing that potential, and then keeping an eye on the legacy platforms and how that all integrates in and actually provides you the efficiencies that you need.
Great, thank you, Matt. Julia, can I come to you next, please? So the innovation team at UHCW sounds like a fantastic concept, and can we go into that a bit more in terms of some of the projects that you've delivered? So when you've delivered a, say, just take one successful project, has there been something that stood out to the reasons why that was successful? And what were some of those reasons? What stood out to you?
I think a key reason is always bringing along staff and your senior stakeholders. So it's also the number one reason why projects fail. You know, it's kind of a do or die kind of thing. To Tamara's point that, you know, if you bring in something new, the technology, the whole point is that it's got to free up time for your clinicians, it's got to make their life easier. And you're not going to be able to achieve that if you don't bring those people along, because they'll be the first to tell you, actually, I don't work that way. That if you add that in, that will take me twice as long as what I'm doing right now. And to Matt's point about efficiencies as well, you just won't get those efficiencies because staff will work around your ideas and around your technology if you don't bring them along, and if you don't kind of communicate the benefits of a project, whether it's EPR, whether it's transformation, innovation, whatever. And that communication, I think, is the key to it, and it means something different to everyone. So we're all probably quite familiar with our emails, but I know back from my clinical days, you would not be able to find me on my emails. You would need to bleep me or find me in person. And I think it's having that understanding and using the right language when you bring staff members along, because innovation and transformation doesn't mean anything to some people. It just sounds like an anxiety, a problem they're going to have to deal with down the line. So unless you explain to them, you know, these are the benefits it can bring your work, we can remove this problem, and do that digging, like Emily was saying, do the proper definition of the challenge to make sure you're not adding more problems than you solve. So if you don't have that staff engagement, yeah, you're not going to have a success at all.
Great, thank you. And Tamara, can I come back to you, please? So what's some of the learnings that you've seen in terms of what makes a project or transformation? I won't use the word digital. What makes that successful?
Well, I'm chuckling at Julia's point about human beings and the way they'll find their way around systems. I mean, the human beings are our biggest opportunity, as well as sometimes it can feel like obstacle. So I've often found that the thing I hate most of all is people that are apathetic. The people that are actively opposed are often really helpful at pointing out all the things you need to be considering that you actually hadn't thought of. So stakeholder engagement is absolutely key. I'm quite a fan of failure. I think one of our most successful procurements recently has been getting a new ED system in. And the reason it went so well is because we had a previous attempt at it and we didn't do very well at all. We got some time limited funding. It did run into COVID, so, you know, to be fair, it was difficult timing. We didn't manage to develop it well, and everyone walked away from that feeling a bit demoralised. But we did a really honest and open reflection on everything we'd learnt from that failure. And as a result, we went into the new procurement with a very clear set of what it is we wanted to get out of this solution. And one of the key things to that was having a really strong relationship with our vendor. And I think that has been absolutely probably the most important thing. In a way, it's a bit like marriage when you go into a big new relationship like this, because there are things that we thought we wanted that actually they pointed out to us maybe that wasn't quite right. And the other way around, you know, things that they thought would work for us that we went, actually, do you know that doesn't work? So, for example, we need clinicians to be able to outcome a patient as deceased, because that's the reality in real time. And they thought, oh, maybe the admin could do that. But so the little things that you need to work through. So it's the stakeholder engagement, it's the learning from failure. And then it's that positive relationship with your vendor, assuming you're buying a system, to have a bit of flexibility on both sides to take it forward together.
Great, thanks, Tamara. Stefan, is there anything that you would like to add and contribute to that?
Yeah, I totally agree with the engagement with the vendor, and in very interesting points around stakeholder engagement. I found exactly the same thing, where quite often the loudest people are the ones that are most opposed to the change end up being your biggest advocates if you engage with them in the right way and understand what's important to them, because they are usually the voice of a much bigger group of people. And we found that in many trusts that we've worked with, and I do actively advocate exactly the same thing. We would say that as part of any big implementation, to try and engage the most outspoken clinicians or affected departments and almost let them flesh test and challenge every element of an implementation, because if they're usually coming from ultimately a positive place of wanting it to be right for the hospital, but then so are we, and so everybody on this call. But if that testing isn't done up front, then there are things that could be missed, and that is a two-way street. So that's the trust listening to the vendor, and the vendor listening to the trust to understand what's important to them. So interesting to hear that, because it's an experience that we've had exactly the same of. And having I'd also say having a true understanding of the current state, and making sure that those senior stakeholders that we talked about understand what the current state is, because that's something that I've found is often not realised. So there are some challenges that are faced in the current state that aren't necessarily seen as challenges if at the most senior level, because they just happen, and they've always happened, and no one's calling them an issue because we've always done it that way. So understanding what the current position is enables you to fully realise the benefits, because you can map out where all the touch points are, where your opportunities are. You might choose to not tackle some of the challenges because it might not be appropriate for the trust to do that, but knowing where they are and knowing what kind of pinch points in the process are absolutely critical from the outset, because you probably won't fully be able to measure your benefits unless you know your starting point.
Excellent, thank you. And I've got one more question for the panel, and then we'll move on to some Q&A from the audience. So if you've got any questions, type them into the chat. Stefan, can I come back to you, please? It's in terms of what good looks like. So I'm going to ask this question for anyone in the audience who might be thinking or planning part of a project around the new hospital build programme. So like in Leeds, they're building a new hospital. What would you say to them in terms of what advice and approach should they take to start building a new hospital? How should they approach records management? What would be your view on that?
So I would say that the key thing here is visibility. So you go back to the starting point, I say, where you fully understand, as Emily said, what the problem is. I mean, I'm personally not calling it a problem, because actually I think there are many things that make records management part of the solution if done right. But if you don't know the current state, then you might not address the right things. And if you don't know what your desired outcome is, in terms of, we're not calling it digital, we're calling it better patient outcome, better patient care, better end user experience, whatever that might be, then understanding what is important to that particular trust, not making it one size fits all, because there are nuances amongst all trusts. Then understanding what those kind of key non-negotiables are and the reasons for those. But then just having a staged plan. So if it's not a new hospital, there are steps that can be gone through, engaging with the vendor to understand what can be done on site and off site, what immediate benefits you can get. There are some space saving benefits that can be realised very quickly without going digital. So if digital is some years off, I would say there is an opportunity to make a fair proportion of the benefit in terms of space saving at a trust fairly quickly. And then you build a solution in that builds towards that ultimate digital future. So from a clinic prep process, for example, you put in standardized, formalized processes where you'd manage the size of the paper record over time. If it gets above a certain thickness, you'd create a new record so that when it comes to digitization, you'd only be scanning the most recent information. You'd merge all temporary notes and loose filing at the point of prep, so that a future digitization, if you do need to scan items, is far more cost effective and standardized. As part of that clinic prep, you'd start introducing standardized forms that support future digitization as well. So where high cost digitizations may be looked at the moment, a bit of preparation over time for those trusts that aren't that close to going digital now would give you some immediate benefit, but then build to a more sustainable, cost effective future digital state. I say for me overall, what good would look like is that space within hospitals is optimized for patient care, for direct patient care. And there are many elements of the paper records management solution that are probably taking up quite significant space in the hospital that could be used for either clinical use or bed space, whatever it may be, that could be realised relatively quickly. Not underestimating the size of the proposal of that change, but there's, according to the ERIC data, over 200,000 square metres worth of space taken up by medical records within trusts across the UK, and based on a private room being 16 square metres, that's over 10,000 bed spaces from just that space without going digital. So there are some benefits that could be realised over time, but I'd say overall it'd be more about everyone being engaged in what digital looks like for a trust, recognising that it's not just about scanning all your paper, because that's not the cost-effective way to do it, but managing that change over time so that the end users are engaged in what decisions are made by the trust, in order to deliver a better outcome for them and the patients.
Excellent. Thank you, Stefan. Tamara, can I come to you next, please, in terms of what does good look like in terms of transformation, but what's on your wish list in terms of delivering that transformation over the next 3 years? What would you like to see?
Yeah, so it's interesting you've added 3 years into that, because my ears are pricking up, because we're in the new hospital programme looking to build a new hospital in 2030. And we've chosen to do that as part of a Hampshire Together approach, rethinking the model of care that we want, because of course we know that the care we deliver today is going to look very different to what is needed in the future. We'll be working in different ways, and the needs of our patients are evolving, rapidly. So we need to think about it, and that takes me back to Matt's point about, we need, how are we going to keep up with all of this as we progress? So there's the kind of, we need to always be keeping our eyes on where are we going with all of this. We need to free up space for medical records. That's definitely one of the things we need to do. So that's on our agenda now. So I think that's the eyes on the distant horizon is a really important one. The other thing is having a very clear understanding of what your plan is based on what the NHS plan is for the next few years, because that's going to dictate your prioritization. So you need to understand how what you are doing aligns with what the NHS needs right now, over the next few years. And very importantly, what specifically is needed to enable those plans and how you're going to pay for it. Because I think we've all been guilty of getting a bit of money, buying a system, and then going, oh dear, we're up for contract renewal, and we never had a budget for that, and we never had the resource for the people to support the programme. That's a bit of a problem, isn't it? And now we're in a headcount reduction situation. So it's thinking out, costed out strategic development, which is aligned with what the NHS is needing. And then maximising, again, coming back to Matt's point, maximising the opportunities of the future. So one of our coolest things I think we've done is take the real-time data from our clinical system, our EPR and our electronic whiteboards, take that information and feed it into a Power BI platform, which provides real-time data to support staff in saying, okay, well, this is what we're expecting coming towards us in the next 24 hours. This is where we need to be focusing to improve our flow, because that's a big focus for the organisation right now. So I guess those are the key areas I've been focusing on.
Excellent, thank you. And Matt, can I come to you in terms of, in your view, what does good look like in this space?
For me, I guess it's these couple of main points. I think we talked about earlier about knowing what the challenges are, but I think what good looks like is having like a measurable outcome of a project, because let's be honest, if you can't measure success, you know, we've all been there where you've got to the end of the project and everyone's a little bit confused of what you were doing and was this even successful in the first place. So I think having that very clear remit is key. So regardless of where you are on this digitalization journey, I think at every stage you need to be measuring progress and have some very clear outcomes. And then the technology that sits behind it. I think we need to be working with more open standards. I think we need to be in a world where, you know, every time you come on to the next legacy platform that you need, it can't be you're starting from scratch. You have to ask yourself how we integrating, how we're moving data around. You almost need that good framework early on. So you have that long-term strategy, you're using open technologies, you're not tied into, you know, particular suppliers, and when you come to integrate the next platform, it's widely understood where those integration points are, what sort of technology stack that you're using, you know, and ultimately it doesn't cost you the earth and, you know, years worth of work to you know, establish the next system that's part of that solution.
Excellent, thank you. So I've got a couple of questions coming, so I'm just going to quickly jump to them. The next question's for Emily and Julia, and it's on, if you could have the perfect steering group of people sat in a room to drive change of digitisation with the NHS, who would that be? And then the question extends to say, would you have medical records managers, clinicians, facilities? The scenario is a trust that hasn't started their journey into digitisation. So be interested to see who you will bring in to manage that journey. That's the question. So Julia, can I come to you and then Emily after?
Yeah, that is a really good question. And my first thought was absolutely everyone, which is perhaps not practical. But in an ideal world, you would have a representative from each of the big groups. And I'm always surprised by, even if you just dig a little below the surface on any project, you'll find at least one team that you didn't know existed before, especially in a trust of our size. And there'll always be you know, a connection there where they need to authorize something for someone else to get something done. So I think to find the answer to that, you'd have to literally walk in, take a journey through the product. So who does this product touch in its journey from the start of one action to the end, and find the fewest number of people that represent all of those stages, which is perhaps not a very helpful answer, but is one of the things we found is you need everyone, but you don't necessarily need them all at the same time, and you don't need them all the time. You can map your project out so that you just get that expertise when you need it, so that you're not finding out towards the end, oh, we can't deploy because we haven't consulted X team.
Thank you, Julia. Emily, is there anything you'd like to add to that?
I agree, ideally everybody, but getting senior buy-in as well is really important, making sure that the senior people are involved in having these decisions to make, because at the end of the day you won't get very far especially if you're just starting out. It will require a lot of money, and those need to be approved. So making sure they're involved and on board as well is very important.
Thank you. What are some of the steps of prioritization for your innovation teams? Say if you get lots of ideas coming in, how do you choose the ones to do and perhaps the ones to do next? What's your prioritization there?
So in terms of ideas specifically, we would typically do like a DFE, which is rank them on desirability, feasibility, and viability. So how aligned is it to the trust strategy, to the NHS strategy? How many, how much need is there for this idea? So trying to find measurable outcomes and or things to measure against, and making sure that the idea is actually wanted by not just that one person, but the rest of the department, or if it's a problem nationwide. Because if you're going into developing something, you want to make sure that you're not the only ones that need it, or else you won't be able to commercialize it. So we'll do it based off of that. If there's money as well, obviously those will probably go up the ranking, because money makes things progress faster, doesn't it?
Thanks, Emily. Julia, is there anything you'd like to add to that?
I think Emily did a smashing job. It is important that we consider all of those things, because like Emily said, sometimes we get presented with a challenge or an idea, and it's just the case that one person needs support with something, or perhaps there's a service that already exists, or it's not an innovation need at all. You could put an A4 poster on the wall and solve that problem. So it's always about checking whether we do need to put technology in, because it's not always needed.
Excellent, thank you. Right, the next question is for you, Tamara. It's I'm interested to hear about your experience of failure. How has that helped with future implementations? How did you reflect? Who did you include? And who did you share this with? Is the question.
Yeah. So just to start with, so I think in order to deliver a project, you do need that senior endorsement, but because you're not going to pass first base without that. But what you really need is that community of practice that underpins all of this, that is going to help you take things forward. And it is that utilising that community of practice to learn from what has worked and what hasn't worked that will help you in your journey. So we have a QI program where we train every member of staff in the organisation to understand the methodology underpinning change. And a key part of that is upfront consideration of what may not have worked in this area before in a very open and blame-free way. And you can use that approach for many things. So we're using it for the new PSURF thing that many of you probably will know about, is the new incident response framework, which is to take people on a journey of understanding what happened in a structured way. So you maybe have an initial huddle, then you define somebody who's going to take forward leading it, but who needs to be engaged with that in the round to understand the problem. And then setting yourself the discipline of having some very tangible, specific outputs from this. One of the things I hate when people respond to a situation of failure is to assign lots of actions to somebody else in the ether who might sort their problems out for them. Is kind of what can we take away from this that we, as the stakeholder group, could do differently in the future, and how can we use what we understand about QI methodology to create the right structure so that whatever we take forward is successful. I hope that answers the question.
Yes, it does. Thank you. Thank you for that. And thank you for the question. The next one is specific to digitising paper records. So Stefan, can I come to you, please? It's when digitising paper records, how do you ensure that there is a standardised approach i.e. preventing each clinician requesting their own specific documentation requirements?
It's actually a similar response to the stakeholder engagement, in that I think where I've seen it work well within trusts, where they've really made progress, is appointing a steering committee that isn't necessarily the normal senior leadership team, but it is made up of outspoken stakeholders from various representative departments. But then you make those people responsible and accountable for the needs of each of those departments, which might be multiple clinical areas. I think from a digitisation point of view, there has been understanding that standardisation is the best thing for the trust, and it cannot be a wish list from various departments. There may be some slight variation depending on specific requirements, but really to optimize digitization, it has to be as standardized as possible. And I would say that where I've seen it work is put the responsibility on a steering committee that, like I say, take responsibility for back briefing the relevant departments and gain the consensus on the kind of contentious points. That point also comes back to the piece on culture change, because part of a barrier to change is a lack of agreement on specific key issues, so that needs to be recognised as well. So there may have to be an overruling part of the kind of project management process that tackles the kind of contentious points. So I would say don't get to a point where you don't make a decision. So you kind of go, oh, we'll do it multiple different ways to cater to various different areas. If there's a clinical reason why an exception is required, then that's a decision for the trust to make. But if it's a preference thing, there has to be a single decision made. And if there's an understanding of the decision-making process and one can't be reached by a steering committee and back briefing, I would say, as part of your program management, have a kind of ultimate decision maker that gets to make a call on that based on the information available.
Great, thank you. Thank you for that, Stefan. The next question is, can I come to you for this one, Matt? It's how important do you feel a robust retention policy is prior to undertaking the digitisation of patient medical records, and how has this been achieved considering how complex it is?
So yeah, I guess for many years there was a sort of a feeling, digitalize it and then not worry about it. Obviously it's very visual when there's a physical footprint of how long you're keeping paper for, but when it becomes digital, I mean, obviously there's still sort of costs and considerations. Obviously now with stricter sort of GDPR frameworks, we have to really consider what we're keeping and how long for. So I guess we've better technology that we now have at our disposal. We can classify documents better, we can understand the content a little bit more, and we can start to have more intelligent retention rules. So it's very common now that we just don't need to have a blanket, 3 years after, decease, that records are removed. We can be more intelligent than that. Also, the needs for supporting systems change, where maybe a type of record is now housed long-term in an alternative system. So actually the need for a copy of that in a document management system is very different than a key clinical file, which you may only have one record of. So I think for us, it's around classifying documents and being able to have that flexibility to apply very distinct rules on different types of work streams depending on that business needs. And as long as your platform can support that sort of way of working, that would probably be the best approach.
Excellent. Thank you, Matt. I've got one more question that's going to be a quick one for the whole panel. And it is, if you could solve one challenge completely solved, just one, in terms of digital data transformation, what would that one be? If you could just choose one. Tamara, can I come to you first for that one, please?
It would be giving our workforce the digital foundational skills that they need to just go past first base, and having a really open and honest approach to evaluating that. So every time we recruit a member of staff, we help them to assess themselves where they're at digitally, and then we help them to get to the place that they need to get to in a progressive way. Not necessarily an induction, but over the next few months.
Great, thank you. Emily, same question for you, please.
I would improve the visibility of existing solutions nationally. So there are a lot of different trusts working on the same solution, most likely, and it would be great to be able to have more visibility on that so people aren't duplicating work.
Fantastic, thank you. Julia, come to you next, please.
Since we've got this magic wand, I would use it to make AI usable and safe and have everyone understand what it means. I think in the transformation space, and particularly EPRs, it's going to only increasingly become an add-on feature, and we're equipping our staff with this tool, and kind of to Tamara's point, they might not always know its limitations. So that's what I would do with my wish.
Thank you. Stefan, can I come to you next, please?
Yeah, I would reduce the space and cost taken up by physical health record solutions, so that resource and spend can be redeployed within the NHS to facilitate better patient care.
Thank you. And Matt, sorry to come to you last.
That's fine. That's fine. This very magical wand. I would definitely insist on those sort of open standards in this magical world where all the suppliers all work to the same type of framework. So no one's tied in to a particular supplier, and you can easily move depending on your needs at the time.
Fantastic. Some great answers there, so thank you very much for those. And we are up on time on the webinar, I'm afraid, so I'm going to have to close it here. I'd like to say thank you to the panel for taking the time out of your day to join us. It's been a pleasure to hear your views and experiences, and I hope everyone in the audience has enjoyed those too. We've had some comments coming in to say that they've really enjoyed the session. It's been very insightful. We've had somebody talk about the reporting safety or incidents app that you first spoke about, Emily and Julia. They thought that was an excellent idea. So lots of positive comments in the questions box. So I'll close the session here. This session has been recorded. We will be doing a write-up of the key themes so you can read or watch it back. And thank you to everyone for joining. And thanks again to the panel for taking the time to join us as well. So thanks, everyone. Have a nice day.
Thank you.
Thank you.
Thank you.
Bye.
Cheers. Bye.
Bye.